Welcome, everybody, to the next edition of Real Time Labs webinar series. Today, we have one of our co-founders, Dr. Dennis Hooper, MD, PhD. He was one of the guiding persons behind starting up Real Time Labs, and we're very excited to have him in today because he's going to be talking about one of our new innovative tests, our UTI test. And this comes about from developing tests that helps find out what underlying conditions are hurting patients. And one of the things that we see frequently with mold toxicity is these underlying infections that occur because of the immune suppression caused by the mycotoxins. And one of these is frequent reoccurring UTIs in patients. So Dr. Hooper wanted to work with our scientists to help develop a test that would help diagnose not just what bacterial species are causing UTIs, but what antibiotics would actually be useful for treating those UTIs. So Dr. Hooper is going to be joining us today and talking about what these UTIs are, why they're important, and how our test works to help treat them. So really excited about having Dr. Hooper here today. So Dr. Hooper is going to be joining us right now. Here he is, Dr. Hooper. So excited to have you here with us.
Thank you. Yes, it's exciting, and I wanted to celebrate this because I'm having this done in my library. I've read all these books here behind me so I can talk about this test. I wore this shirt that I got from Cameroon from a colleague, and it's going to, if there's get some areas where it's boring, the shirt will keep you awake. So hopefully that will help everybody understand what urinary tract infections are.
Yeah, no, I'm really excited about being here with you, and I think that this is going to be really useful for our audience. And so if you want to go ahead and share your screen and start, I will bow out and come back at the end to see if we have any questions.
Well, I'm trying to share it. There. Can you see it there, Matt?
Yes, sir. We just have to go ahead and hit present.
Right. Is that okay? Can you see it?
No, that looks good to me. Thank you, Dr. Hooper.
Wow, I can do something with technical stuff. So we're going to talk today about UTIs and how we test for them. Many of us have had these, or many of us have had family members that have had them. Many of us have had people who have complained, I think I have one, and the doctor doesn't know what to do about it. Many of the patients are having cancer therapy, and they are saying, I know I have something because it burns, but I can't understand why nobody tells me what's going on. So we're going to talk about these UTIs. The goals of our webinar is what is a UTI, what causes it, what are the symptoms, what are the clinical characteristics that a doc would see or a nurse practitioner, what are the current standards for evaluation, what's the current gold standard for testing, and what is the upgrade that in the UTIs that Real Time Lab is proposing and is presently doing. What's a UTI and what can cause it? They develop when microbes enter the urinary tract and they grow or proliferate and they cause an infection. Bacteria are the most common cause of UTIs, but fungal infections are another pathogen that can cause UTIs. So what is a UTI? It's an infection in any part of the urinary system, including the kidneys, ureters, bladder, and urethra. Most infections involve the lower urinary tract, which is the bladder and the urethra, and women are at greater risk than men. So what are the clinical characteristics that usually the docs will document in their progress notes? It's usually acute within hours or days. It can worsen in severity. They can have blood in their urine. It can be a simple UTI, but if it becomes more complicated, it can progress to pyelonephritis or kidney infection. So what are the common symptoms that usually present to us for a UTI? They have pain or burning when they're urinating, and that's called dysuria. They're frequent urinations, polyuria, and that happens at night usually, but in the daytime especially, they note that and they have to run to the restroom real quick. Feeling the need to urinate despite having an empty bladder, so that's urgency. And then if there's blood in the urine, it's hematuria. And if it's pressure or cramping in the groin or lower abdomen, we can say that the notes say pelvic pain because they don't know where it is exactly. What's a clinical differential diagnosis of a patient with the symptoms? They're either fungal infection, interstitial cystitis, which is in the wall of the bladder, bacterial vaginosis, and then sexually transmitted diseases such as herpes, chlamydia, gonorrhea, trichomonas, and then, of course, bladder cancer. One last one I haven't listed is cancer that has metastasized from other areas like prostate or breast. What are the current clinical standards for evaluating these patients with a possible UTI? Well, the first thing you have to take is a clinical history. This takes time, the physical exam, and then a urinalysis, which is the gold standard. It looks for leukocytes, nitrates, and blood in the urine. Then they always will order a urine culture. I say always, they should, if they've got down to this point. And then in that urine culture, they'll say for culture and sensitivity, which is telling them what antibiotic to use. Current standards, the gold standard is urine culture. And the urine culture is not always performed, especially in primary care and emergency departments. And the urine culture is slow, and emergency departments need to move things fast. And that usually requires 24 to 48 hours to report the organism and provide a resistance profile. Symptoms usually are so distressing and so painful that the patients convince the doc either by screaming or by begging to give them some kind of empirical management antibiotic. Since these acutely unwell patients with UTI symptoms may not be prepared to wait for up to 48 hours, and usually it's 72 for a culture result. So the limitations of the gold standard are there are limitations with telemedicine because you can't meet with these people easily. There's a lack of examination physically, no access to diagnostic material, and do you have a negative UA? The culture is looking, I'm going to move my picture up a little bit. The culture is looking contaminated or dirty. That may or may not be something helpful. Guessing antibiotic choice is your prerogative as a physician because they're begging you, and that's empiric treatment. The risk of worsening bacterial resistance, which you hear all the time, I don't want an antibiotic because the others are going to get resistance to this. They change antibiotics, and there's delays of care, and there's a risk of worsening the UTI to go to pyelonephritis or kidney disease, urosepsis, which goes into the bloodstream. And these patients, if they go on further, get delirium. Now, I know physically and personally that this happens not with me, but with relatives that have had UTIs and they get urosepsis and they're admitted into the ICU for IV treatment. They also get very confused, and the older people are sometimes thought to have a sodium deficiency but when they have their electrolytes done, their sodium is fine, but they're so confused that they have this delirium. Okay, the asymptomatic bacteria is a big discussion in the literature. The definition of such is isolation of significant colony counts of bacteria in the urine in a person without symptoms. So he's asymptomatic, but he's got a lot of bacteria, or she. Remember, common symptoms of cystitis, or the inflammation in the bladder, are dysuria, frequency, urgency, and suprapubic pain. Common symptoms of the kidney disease or pyelonephritis are fever and flank pain. Common symptoms of catheter-associated UTI are fever and suprapubic tenderness. So that is really helpful in your differential. The foul smelling or cloudy urine does not indicate a UTI. Put that in the back of your mind. Mental status changes alone do not indicate a UTI. Pyuria can be seen in patients with UTI, but is not diagnostic of a UTI in the absence of urinary symptoms. Okay, so what's pyuria? All it is increased white blood cells in the urine, or pus. And it's thick, discolored, and the body makes it to help fight off an infection. It consists of the white cells. If you have pyuria, diagnostically in a laboratory, you have 10 or more white blood cells per cubic millimeter of urine. That oftentimes doesn't key out helpfully to the doc, because sometimes in the laboratory, people don't know that they should count very well, and you wonder what the QC of the laboratory for pyuria is, or quality control. Sterile pyuria is a type of pyuria in which you have white blood cells, but they can't find any bacteria. That's in culture. The mental status changes in asymptomatic bacteria and UTI show bacteria and delirium are both independently common in the elderly. I have to move my picture again. Although patients with although patients with a symptomatic UTI may present with delirium, no evidence suggests that delirium, any falls, or confusion are symptoms of a UTI. That is one that where my mother, who was in her 90s, would get delirious, and they thought, oh, this is a UTI. And then when they did cultures, there was nothing, and yet they gave her an antibiotic and she sort of cleared up. Asymptomatic bacteria is not associated with a decreased feeling of well-being. In other words, you can have this bacteria in your urine and you don't have any symptoms, and it's not associated with decreased feelings. So you feel great sometimes. No difference in insomnia, malaise, fatigue, etc. If a patient has signs of systemic infection and delirium, empiric antibiotic therapy may be warranted. Now that you see in the care centers a lot, they will give nitrofurantoin or something as a empiric antibiotic. So the guidelines recommended screening and treating for asymptomatic only are present in two situations. If they're pregnant women at 12 to 16 weeks gestation, you want to prevent pyelonephritis, preterm labor, and infant low birth weight. Or if they have an impending urologic procedure in which mucosal bleeding is expected, they may prevent urosepsis, and this does not include placement of a urinary catheter. So those are guidelines recommended by major urinary groups that study the urinary tract infections. The asymptomatic bacteria is common, and I've noted the symptoms by references that I have at the end of the webinar. And you'll see that healthy menopausal women have a low prevalence, and people with long-term indwelling urinary catheters have a high prevalence, and people in between fit in all those categories. The long-term resident cares are very concerning to me as well as others about these incidence and prevalence of the urinary tract infections. Asymptomatic pyuria, that's you don't have any pain, you don't have any symptoms, but you have the white blood cells in your urine, and they can't find any bacteria. The women with diabetes are greatly have a great prevalence. The elderly institutionalized patients, high prevalence, and dialysis patients. Patients with long-term catheters, of course, are high. So pyuria in patients with asymptomatic bacteria is not an indication for antibiotic therapy. So just because you have pus in your urine and they don't feel bad, it's not, you don't give antibiotics. Other causes of pus in the urine to consider are sexually transmitted infections and interstitial nephritis. So that should be in your differential. So the urinalysis and culture indications when patients have symptoms of UTI. Do not send urine cultures for foul smelling or cloudy urine because they're usually negative. Do not send urine cultures for routinely on admission. So when you go into an ER and they're going to admit you, people will say, don't I get a urine culture? No, it's not a routine thing unless you have those symptoms of UTI. They are not done routinely before or after a catheter change. As part of a fever workup, you don't do these either if there are no signs or symptoms in a urinary tract infection. And you don't do UAs as a test for cure because you can have antibiotics on board. The bacteria may be negative, but you still have a urinary tract infection. And you must ensure that urine cultures are collected properly, which it's interesting that people expect that patients read the instructions instead of telling them. And that's not easily done to pediatric or to elderly. Urinalysis results, positive UA is greater than 10 white count per high-powered field. If they use the dipstick, the leukocyte esterase indicates white blood cells and nitrates indicate bacteria. Positive urine cultures, right now, if you do them in the microbiology lab and they don't have a catheterized urine, anything over 10,000 bacteria or colony-forming units per ml of a urinary pathogen is considered something that they work up. If it's a catheter urine, anything greater than 1,000 colony count forming units is considered a pathogen. Now, these are the criteria of the gold standard. That's not what we're talking about. We should obtain blood cultures when you expect pyelonephritis or urosepsis. So if they have fever or flank pain, get that blood culture and do them ×3 over a 30 to 60 minute interval. This is what the bacteria look like in a drawing. On the right side, it's called gram-positive bacteria, gram-negative on the left, or right side is gram-negative, right side is gram-negative, left side is gram-positive. The biggest point to take away from here is the peptidoglycan. Peptidoglycans in gram-positive bacteria are very thick, and they're very thin in the gram-negative. So we do a stain called gram stain, and the gram stain consists of crystal violet. It gets caught up in the peptidoglycan and all the bacteria, and it can't get out even when we wash it out. It stays in the peptidoglycan very, very heavily. In the gram negatives, hardly any of the crystal violet gets caught up in the peptidoglycan because it's too small. We do a counter stain with a red stain called safranin, and it doesn't discolor the blue stain at all. It does make the gram negatives look red. So we have purple or blue and red, and that's a gram positive, gram negative. Real Time has decided to upgrade their UTI testing by reading the literature and listening to UTI seminars as to what is missed in the gold standard. So it's developed a rapid PCR test to detect UTI pathogens. This includes the urinary tract microbiota profiling from bacteria and fungus. Now, this is an option to add when you're doing the mycotoxin testing, because these patients complain of burning, and that's not due to the mycotoxins. These are the bacteria that are defined in the real-time labs PCR. We do 17 gram negatives and gram positives. At the very bottom, if you would take and list this, you would count 17 bacteria, but we advertise 18 bacteria because Staphylococcus xylosis and Saprophyticus are very closely tied in the DNA, so we count that as one. But there's really 18, and then there's one fungus called Candida albicans. That's a yeast. What are the benefits of PCR? It reduces false negatives. It detects many organisms in same sample. We have done many chronic infections that we get 2, 3, and even 4 bacteria. Includes a panel indicating resistant gene presence. And it includes the physician's consultation with medical department of real time on what they're using and on what we are suggesting by our DNA testing. We report results within 8 to 12 hours, usually. The benefits are they provide rapid, accurate, and targeted molecular diagnostics for UTIs. It eliminates guesswork in diagnosing and treating UTIs. You don't have to give an empirical drug because we're going to tell you before the end of the day what they're resistant to. You use real-time PCR molecular technology. It detects 98 to 99% of all bacteria and fungal targets that are documented in peer-reviewed literature. It reduces the guesswork of medication choice because you're not going to send somebody home on nitrofurantoin and say, call us in 5 days if you're not feeling better. It reduces the delays in diagnosis because we're going from 48 to 72 hours by culture to 12 to 18 hours in actually giving the results to you and the patient. It reduces delays in treatment and it reduces the risks of complications. In other words, that patient should not get urosepsis or pyelonephritis. So how does it work? The only things that you are needed to take away because you're not a molecular group is we take DNA, which is double-stranded unless it's a virus, and it's double-stranded DNA, and we amplify it. So if we get one piece of DNA in the urine, we can actually multiply it to get many and identify. First step is we have to denature it, then we bring it back together and anneal it, then we extend it. And we repeat this 25 to 35 times to exponentially produce exact copies. This is a short video on how denaturing, annealing, and extension of DNA work, and something you probably will remember from this seminar.
Polymerase chain reaction, or PCR, uses repeated cycles of heating and cooling to make many copies of a specific region of DNA. First, the temperature is raised to near boiling, causing the double-stranded DNA to separate or denature into single strands. When the temperature is decreased, short DNA sequences known as primers bind or anneal to complementary matches on the target DNA sequence. The primers bracket the target sequence to be copied. At a slightly higher temperature, the enzyme Taq polymerase, shown here in blue, binds to the primed sequences and adds nucleotides to extend the second strand. This completes the first cycle. In subsequent cycles, the process of denaturing, annealing, and extending are repeated to make additional DNA copies. After 3 cycles, the target sequence defined by the primers begins to accumulate. After 30 cycles, as many as 1 billion copies of the target sequence are produced from a single starting molecule.
Now, that's how we develop those. Now we have to know how to read them on our thermocyclers.
In contrast to traditional PCR, where the presence or absence of a DNA sequence is analyzed upon reaction completion, quantitative PCR, or qPCR, monitors DNA amplification as the reaction progresses. In qPCR assays, reaction progression is monitored by an increase in fluorescent signal. The fluorophore can be a double-stranded DNA binding dye, most commonly cybergreen 1, or covalently attached target-specific probe, as in text. In CyberS, the dye fluoresces when bound to double-stranded DNA, but does weak fluorescence of single-stranded DNA. This results in an increased fluorescent signal as the reaction progresses and double-stranded DNA is formed. The most common probe-based assay is a 5' nuclease assay, known as TACMAN. In TACMAN assays, the 5' flap endonuclease domain of TAC DNA polymerase, target-specific probe, separating a fluorophore on the 5' end from a quencher on the 3' end, resulting in an amplification-dependent increase in fluorescence. A thermocycler, coupled with a fluorimeter, modulates temperature during DNA amplification, while also monitoring fluorescent signal at each PCR cycle, generating a real-time qPCR curve. There are 4 distinct phases within the amplification curve: lag, exponential, linear, and plateau. Lag phase, amplification occurs, but the signal is not strong enough to be detected above background. The exponential phase is used for quantification because it produces a fluorescent signal measurable over background and contains an abundance of reaction components. Doubling event at every PCR site. Over the background fluorescence, a quantification cycle, or CQ value, can be determined. CQ values can be used to evaluate relative target abundance between 2 or more samples, or to calculate absolute target quantities in reference to an appropriate standard curve. qPCR can also be modified to detect and quantify RNA. Interpretation of qPCR data requires careful experimental design and analysis. For parameters on designing and reporting qPCR experiments, please read the MICE guidelines, which have been established to ensure consistent experimental design and data analysis appropriate for peer-reviewed publication.
So now we know how to collect them, how to send them to, well, we have instructions how to send them to the laboratory, and then we know how we prepare them to look for an exponential growth in just 1 or 2 fragments of DNA. But the big question is, well, what are we going to treat with these UTIs? What antibiotic? Now, the antibiotic is coded for resistance by certain genes, and we're looking for those genes on the most commonly used antibiotics in urinary tract infections. The treatment of an asymptomatic bacteria is not beneficial. We need to take that away from this seminar. Randomized controlled trials have demonstrated a lack of benefit of antibiotic treatment if you have an asymptomatic bacteria in the following populations: healthy non-pregnant women, diabetics, especially diabetic women, patients with long-term indwelling catheters, older women in the community, elderly nursing home residents, renal transplants, and patients undergoing orthopedic surgery. So the whole issue of this slide is we don't treat asymptomatic bacteriuria if it's in these patients, unless they have a presenting symptom. So then they become not symptomatic or asymptomatic. They are symptomatic. Treatment of an asymptomatic bacteria may cause harm. Treatment is associated with adverse events and development of resistance, as we talked about earlier. An increased risk of subsequent UTIs occurs in older women and people who are diabetic or have some kind of immune compromised system. So we want to make sure there's treatment of that we take away from this, asymptomatic bacteria treatment may cause harm. The genes that code for resistance to specific antibiotics. I don't expect that anybody memorizes this because it's been hard for everybody here at Real Time to adapt to this, because we're used to the old Kirby Bauer technique of saying, oh, you measure the disc diameter that's impeding growth on media and say, oh, this is resistant to ampicillin or carbapenem, et cetera, et cetera. So now we look for these genes. So we have to find the DNA of the bacteria first, which is what we're doing. But in those results that you see on PCR, we're also looking for these different genes. So we look for ERMB, all these ones that are in yellow, which don't mean a thing to anybody until you look at the results from Real Time. These are the antibiotic families we measure: the macrolides, the beta-lactam carbapenem, beta-lactamase, which is the beta-lactamase inhibitors, glycoproteins, the beta-lactam, which is methicillin, quinolones, and sulfonamides. The genes are listed on the far right, coding for each one of these, and the examples are, so if we say that this is coded, an ERMB gene is saying you're coding for resistance, you don't want to give the trimethaprins or the Bactrums. Nitrofurantoin would not help these patients. Ceftriaxone will not help them. These macrolides are not helpful if you have an ERMB resistant. If you have a resistance to the BLA KPC, then it includes the carbapenem antibiotics, which are a type of beta-lactams, and they use these in E. coli and Klebsiella. However, these Klebsiellas can be extended spectrum beta-lactamases, and so you have to, if this gene is there, you don't treat Klebsiellas with a beta-lactam or a carbapenem. I'm sorry, I say that all wrong every time. The beta-lactamase inhibitors, if it codes BLA-SHV, do not give amoxicillin, ampicillin, penicillin, cephalosporins, aminoglycosides, clavulanic acid. It's like pouring water on a huge fire and it won't work. If you have resistance to vancomycin, you will have the gene positive for VAN-B. And vancomycin is usually used only IV in the hospital, but if you have a urosepsis and they treat with vancomycin, it won't help. Beta-lactam methicillin is actually a penicillinase-resistant beta-lactam antibiotic. So methicillin is used occasionally, but not often. MEC-A is the gene that is coded for. The quinolones, nalidixic acid, ciprofloxacin, levofloxacin, and moxifloxacin are coded by the gene QNRA. So if Real-Time Lab says QNRA is present, do not give ciprofloxacin. However, if these other genes are present and the resistance to QNRA is not present, ciprofloxacin is given many times to many people. There's a whole discussion of why not to give Cipro and why to give Cipro, but this is a major reason why you would want to give it, especially in recurrent urinary tract infections. Sulfonamides are listed here. Only you would not give them if the SUL1 gene is present, and that is azulfidine, diamox sequels, and gantricin. A lot of gantricin is given to patients, and that should not be given if you have the SUL1 gene. If you don't have those, then you have a choice of going to anything that's cheaper and easier. And if they still reoccur, then you have to rethink using a stronger antibiotic. So, that is it in Real-Time Labs' new testing. I have provided references, which are about 5 pages. of references that have to do with everything I've discussed here today. If you have questions, you can send them in to us at by sending an email or however we're doing it. Matt can explain that. And I will attempt to answer them by 24 hours after this seminar. I'm not opening it up for discussion because I covered quite a bit of material in a short time, and I think this will be available on our website soon. So I'll give this back to Matt.
No problem. Well, let's say like if anybody has any questions, please email us at info@realtimelab.com. And then those questions will make their way to Dr. Hooper, and he'll answer them, like you said, as quickly as possible, most likely within 24 hours. A couple things I wanted to talk about on ordering. This test is available in 48 different states, 50 if you have a doctor order them in New Jersey or in New York. But besides that, you can order them yourself off of our website in those other 48 different states. Medicare covers this test, so if you are a Medicare patient, you can submit this test and Medicare will cover it. This is a very like easy urine collection, and we have instructions on our website how to collect the sample. Again, if you have any other questions, feel free to send us an email at info.realtimelabs.com. We're going to be very happy to reach out to you and answer your question as quickly as possible. Anything you want to say before we leave, Dr. Hooper?
Yeah, I have a couple more things. One of the things they don't have to worry about is heat, the temperature or the freezing, because DNA is sustainable in those kind of temperatures. So they can ship it under the conditions of UPS or FedEx. Also, Real Time in their marketing is going to start talking to urologists, OBGYNs, and the patients' facilities that handle the elderly. And if people are watching this and know what I'm talking about with their elderly family, you should push to use this test. And it will help you feel more comfortable with where your loved one is in that facility, because there's patients being cared for at the newest techniques, and quality of care has improved. There, I'll stop.
No worries. Thank you very much, Dr. Hooper. Well, again, very welcome for everybody listening to this live, and as well as those listening to this as a recording. We are here for always here for you. We are, obviously, as our name says, we are the champion of the undiagnosed, and we are here to help in any way that we can, either through providing testing or consultation or helping you find the resources you need. Again, thank you very much for joining us, and hope to talk to you soon. Thank you.
Goodbye.